Hi, my name is Suzanne Farrell. I'm a consultant in anaesthetics and intensive care here at Hare Myers and have been for about the past 10 years. Now, my interest has been for a long time in high risk patients for anaesthesia, and I've spent 10 years delivering anaesthesia for vascular patients. So it's kind of brought me to this point where I'm interested in all kinds of risk assessment for any number of surgeries. So I have set up this clinic to spend a bit more time with these patients, and I'd like to spend a little bit of time today telling you how I've managed to do that. So, if we can go to the slides, I will advance them and hope you can see them. So, what the quality team wanted to know was what the drivers were for this. Why did I do it? What my approach was. How did I do it? What challenges I've met along the way. Now that I've set the clinic up, what have been my outcomes and what impact has had that, in particular on patients? And then, in addition, what have I learned from all of that? So, I'd like to address these things over the next 10 minutes or so. So, the drivers are really patients. That's always what it comes down to. That's why we come to work. So, I'd like to introduce you to Loan. She's given her she's given consent for her participation in this. And she's a 63-year-old lady that we met last year with very severe chronic obstructive pulmonary disease and severe obstructive sleep apnea. The breast surgeon, referred her to anaesthetics for an opinion on whether she would be suitable for curative surgery. So, in other words, a mastectomy for her breast cancer. If you want to hear her story from the horse's mouth, we recorded it on video and the link is attached there. However, since we're a bit short of time, what I thought I would do is just summarise our interaction with her. And really, this is what it boils down to, is the bran flakes, the bran flakes. Now, I have used this slide many times, but I make no apology for that because I think it illustrates an excellent point. Now, most of you will know what the bran is, but for those of you who don't, the bran is what are the benefits of this treatment? What are the risks of this treatment? What are the alternatives to this surgical treatment? And what if I do nothing at all? So in the 80s, when I grew up, my mother wanted me to eat bran because, let's face it, fresh vegetables were hard to come by. So what I did was I said, okay, mum, I'll eat bran flakes with raisins. Now, my best friend, on the other hand, preferred to eat all bran and she would nuke it in the microwave until it turned into something closely resembling wallpaper paste. You couldn't get me to touch that bran. And so my brand's not the same as my best friend's brand, even though we are quite like-minded people. So basically, what I sometimes have to do in the clinic is ask the surgeon what their brand is and what they're actually offering the patient. And also ask the patient what their brand is. So what do they think they're going to get out of having the operation? So I'm going to close all these pop-ups. You can't, they're not too destructive. And carry on. Keep calm and carry on. So, what do patients think when you ask them these questions? Well, it becomes very clear that actually, a lot of the time, the patients really don't know the ins and outs of what's been offered. For Loan, she was pretty switched on, and she thought that the benefits to her by having surgery would be to become cancer free. The risks, she wasn't really sure, despite having medical problems that she understood well. She knew that her COPD and her obstructive sleep apnea were a risk, but she didn't really know how that would translate into what might happen to her. Alternatives, well, she's watched TV, she's, keeps up to date, and she thinks that chemotherapy might be an option, but that not having surgical treatment would be lengthy and less successful as an option. So, as I've said, you can hear it from her here on the link provided. However, where did we go from here? Well, this is what my clinic tries to do. We try to change the style of our consultation to shared decision making. We try to tell the patients straight out the gate that they're not here for a pass or fail to decide whether they're to rubber stamp them fit or not fit for anaesthesia. What we're trying to do is give them the information that will help them to decide whether or not surgery is the best option for them. So we're managing risk, we're being personalised, and we're definitely changing our style to shared decision making. All these things are tenets of shared decision making. So how did I do it? Well, first of all, I talked to a lot of my colleagues and I started slowly to get some enthusiasm, and I built a team. And really that team has boiled down to 2 or 3 people who have given me their time for free so that I can get this up and running. So thanks tremendously to Graham Carroll, Vanessa Valance and Shona McConnell. I then sought some advice from experts in communication, and these guys for me are palliative care physicians. They are really the best people to talk to when you want to get better at having difficult conversations. So I got great steer from Kirsty Boyd, who's a palliative care academic in Edinburgh, and I asked her if I could use some of the tools that she had developed in collaboration with NES, so NHS Education for Scotland. Then within Here Myers, I basically went on a kind of mini roadshow, and I emailed all the consultants, all the lead surgeons, and said, listen, can I come and talk to your CPD? I've got this idea for this clinic I could set up. So I went and spread the word, presented the idea at our CPD, at our Realistic Medicine conference, whoever would listen to me, basically. I said, listen, I'm going to see all your high-risk patients, and I'm going to spend a bit of time with them, more time than you have. I won't necessarily do it better, but I'll just do it a little bit differently. So please, please, please don't tell the patients that you give them the operation if the anaesthetist says it's okay. Please tell the patients, if you realise that they are ultra high risk, that actually, listen, I wonder if this is the right thing for you. Maybe we need to spend a bit of time exploring that. I'm going to send you to somebody who's got that time. And that is me and a colleague of either Graham, Vanessa, usually. So what were the challenges? Well, there's no money for anything, as we know. There's no time to do anything, but we had to press forward somehow. So basically we did it unfunded for the best part of a year. And we just made the time in our non-clinical time. We hit some attitudes of, well, why do you need to do anything different? We see high-risk patients anyway. But do we really put the question back to them every time? We see high-risk patients a lot of the time, but I think for many anaesthetists, it's easy to advise them. It's easy to say, if you were my relative. It's more difficult to truly give the decision back to the patient. And that's partly why I've set this clinic up with 2 consultants, so that at the end of the day, if you're saying to a patient, if you're offering to them, listen, we will support you, you need to decide if you want it, then it's not just me that's saying so, it's another consultant as well. So I think there is definitely a strength. It's a collaborative way of working. You've got 2 anaesthetic opinions for the price of 1. So if the high-risk patient turns up on the day of surgery, a different anaesthetist, I hope, will feel supported by the fact that this has been considered fully by more than 1 colleague. So what are my outcomes? Well, the outcomes have been great, largely. If you spend time with the patients and tell them what high-risk surgery really means, actually, across the board, so if you lump all the specialties together, and these are the specialties that I've seen: general surgical, eyes, orthopaedics, vascular and breast. I've now seen 48 in total, and 24 of them have opted out of having high-risk surgery. So that's phenomenal. So 50% of people actually come to a point of thinking, this isn't the right choice. So for general surgical, you can see that the numbers opting out are higher. For eyes, it's 50-50. For orthopaedics, more people go forward, so more people go for surgery, and that's understandable because there isn't really a good alternative to replacing the hip for a hip that's extremely painful, and they've already tried all the painkillers under the sun. The vascular numbers are low because we're lucky enough to still have largely paired surgeon and anaesthetist. So the 2 consultant opinions really comes from the 2 of them, comes from the surgeon and then the anaesthetist. And in an ideal world, that's how I would run this clinic as well. But the problem in this day and age is that the general surgeons in particular no longer have a regular anaesthetist. So it's very difficult for them to have that relationship and conversation with the regular anaesthetist and the patient. So that's why we've ended up seeing predominantly a large group of general surgical patients and orthopaedic patients for whom the surgeon no longer has a regular working relationship with the same anaesthetist. So what has the impact to NHS Lanarkshire been? Well, we've not saved money because the money doesn't truly get saved. It goes to treat other patients. But what we've done is we've avoided spending money in theatre. We've avoided spending money on bed nights. And I have estimated average length of stays for each of these, for all the types of cases that we've done. And I have estimated the number of hours that each operation takes. But then the real figures that I've based this on are theatre costs, which are £1,400 an hour, an ITU bed stay, which is about £2,000 a night, and a ward bed stay, which is about £800 a night. So when you extrapolate time taken in theatre, number of bed nights, number of patients that have decided not to have surgery, we're talking about something in excess of £350,000 that has not been spent on a hospital stay. So how do patients benefit? This is really what makes me tick, if I'm being completely honest. The fact of them opting out of surgery is only good for me if it's right for the patient. So what I do is I explain the risk to the patient in their own terms, and I try to meet them where they are. That's really what I'm aiming to do. So here's what the patients have said in feedback. Here's the free text, if you like. The risks of going through with it were made clear to me. They helped me and my family understand. I had no idea what the risks were before. I really appreciated all the time the doctors spent with me. I'm grateful that someone would listen to them. They understood all my health issues and they explained it in a way we hadn't heard before. So that for me is good. What that reflects, I think, is that is a therapeutic consultation. We've spent time listening to patients and listening to what their healthcare values are and trying really to understand them as an individual. So what I have learned from them is that risk is difficult to explain. It's incredibly difficult to explain. Health literacy and numeracy is poor. We know that. So even with the aid of infographics that I have plenty, it's still difficult for patients to grasp what we as doctors understand as risk. Like, for example, if you ask patients, what do you think the anaesthetic risks might be? They say, well, I don't think there are any. Or they say, well, I think I might not wake up from the operation. And actually, those are two extremes, neither of which are likely to be true. And the truth is somewhere in between. So our job, I think, our skill is to take the medical lingo and explain it to patients in a way they can understand. What matters to patients? Well, what I hear people say time and again is that they don't want to lose their independence. So if you tell them that you could maybe get them through the operation, through a high dependency stay, through a ward stay, but that might come at a cost to them because of their frailty or other health conditions, and that they might not get back to the point of independence that they currently enjoy, then that's often the moment where, for many patients, the penny drops and they think, well, actually, do you know what? I don't know if I do fancy this at all. Maybe I'll just continue to live well for whatever time I have left. And that is difficult. That is difficult asking patients to consider that. Often you're asking them to consider the possibility of, well, what if we just carry on and, you know, we treat the consequences of your cancer rather than having the massive operation to try and remove it. However, patients relate more to debility than they do to death, and it seems to be a much realer concept. People don't believe they're going to die. You know, they think they're invincible. They don't talk about it, even though we all know we're going to die. But people really, really don't want to live badly, and they don't want to live a dependent life. So what happened to Loan? Well, when we gave her the Bran, we asked the surgeon, we got her Bran, and we got from the surgeon the Bran, and the surgeon said, well, this would be a curative resection. We think the risk of death would be between 1 and 5%. However, the alternative is that a hormonally responsive tumour can be controlled with medication. If we don't do anything, it might spread or fungate. And we could consider surgery at a later date if it responds well to the hormone treatment, if she could be optimised. What did Loan say when we presented that to her? She said, no thanks. Well, I'll take the hormones then. I am not losing my independence. I am absolutely not losing my independence. And if the hormone treatment is just as good, then I don't need to put up a fight for having the surgery. So she did a complete about turn. She came in all guns blazing, saying, well, I know there are risks, I'm going to take them. And she walked out the door happy. And I'm happy to see, from a breast cancer point of view, she continues to do well. So like I say, you can hear her story on the video. If you want to hear any more from me droning on about this topic, I've recorded a podcast and it's available on Spotify. If you have a long, boring journey ahead, there's the link for that also. So thank you for listening and goodbye.